Avinash sir, Patil sir, can we start?
Yeah.
Yeah.
Good evening, everyone. On behalf of the organizing team, I welcome you all the respected faculty members and the participants today for today's online session by the Department of Psychiatry, D.Y. Patil School, Navi Mumbai. The Dr. D.Y. Patil School, Department of Psychiatry has always attempted to pursue academic excellence. In that vein, we started a PG lecture series for postgraduate students of psychiatry from all over Mumbai and its periphery in 2015. We have another dimension to it now. We present the PG Psychiatry video lecture series as an extension to it. This lecture series was started by Dr. Rashmin sir and in 2015, and this has helped all PGs all over, not only in Mumbai but all over India, by the variety of experts, and this has helped them prepare for their examination and enhance their skills in the field of psychiatry. We hope this helps PGs, psychiatrists alike from all across the countries. We continue to strive hard to make further advances in our teaching endeavors. It's my privilege here to introduce today our esteemed chairperson, Dr. Pradeep Patil sir. Sir is professor and HOD at Department of Psychiatry, Datta Mege Medical College. He was former professor and HOD Department of Psychiatry, JNMC Savangi, Wardha. Sir was director at Isha, Institute of Socio-Psychological Health and Addiction Psychiatry, director Central India Institute of Clinical Hypnosis. Sir has vast experience of 35 years, numerous publications in national and international journals with many awards for his under his achievement. Award for Social Welfare Department of Government of Maharashtra, award for work done in de-addiction and rehabilitation, Shahid Smarak Samiti Ashti for psychosocial rehabilitation, Rashtrasanta Tukdoji Maharaj Yuva Manch for the work in de-addiction and rehabilitation. With this, I request Dr. Pradeep Patil sir to take over the further proceedings. Over to you, sir.
Thank you, Dr. Chetan. This is a very good initiative started by D.Y. Patil University Department of Psychiatry, and so many students are being benefited, faculties are being benefited out of that. So coming to today's topic, that is neuropsychological symptoms in dementia and overview. Traditionally, dementia has been viewed primarily as a disorder of memory. However, as our understanding has evolved, it has become increasingly clear that dementia represents a complex interplay of cognitive, behavioral, and psychological changes that extend far beyond memory impairment alone. Neuropsychological symptoms ranging from executive dysfunction and language disturbances to behavioral and psychological symptoms such as apathy, agitation, and psychosis not only help us in early diagnosis and subtyping of dementia, but also significantly impact patient functioning and caregiver burden. In fact, in many cases, these symptoms are the earliest indicators of disease and often the most distressing for families, making their recognition and management absolutely crucial in clinical practice. Today's session aims to explore these dimensions in depth, bridging neuroanatomy, clinical presentation, and practical management, while also reflecting on the unique challenges we face in our settings. Dr. Avinash DeSouza is well known. He needs no introduction. He is a consultant psychiatrist and founder trustee of DeSouza Foundation and research associate, Department of Psychiatry, Lokmanya Tilak Municipal Medical College, Mumbai. has over not only 100, 200, 500, but more than 900 publications in national and international journals. Hats off to you, Dr. Avinash. And he is editor-in-chief, Indian Journal of Mental Health. Whenever we call him as a speaker in Vidarbha, so many adolescents, they are eager to heard about him. So without wasting time, I request Dr. Avinash to start his deliberations.
Well, good evening, everyone. What I'm going to present is a very flowing overview of multiple neurological symptoms that we see in dementia. Over the next hour, whatever I can cover, I will try and cover. If the need arises, we may do a second part later. We've not thought of it right now. For postgraduate residents who are attending, if at the end of this lecture you take some time out and go and read the second chapter from Lishman's Organic Psychiatry book, William Alvin Lishman. It's a very famous book. You will get an deep in understanding of this. What I'm going to do is just take you through more with clinical presentations, bedside assessment, and multiple other factors, because we do not have the time to go into everything in detail. If we go into detail, it is a like 4 or 5 hour workshop. So we start with the frontal lobes. We're also assuming you know a little bit about brain anatomy here. So we're not going to be teaching you anatomy per se, but talking about anatomy. So we all know that the frontal lobes is the newest area of the cortex, and there's a large amount of connectivity that it has with other areas. It is a reflective lobe. So one reflects, one thinks, judgment, multiple things are made to the frontal lobe. And it is also part of the limbic system because the neocortical representation of the limbic system is here. Motivational and emotional understanding happens from here. Now, when you look at the frontal lobe damage in patients with dementia, you see all sorts of deficit. So you see elementary neurological problems because the motor area is there. There are skilled movement issues, which you may see there. Language and speech is affected because Broca's area is there. Memory also gets affected because thinking is there. Executive function, which is the hallmark of the frontal lobe, also gets affected. And because the frontal lobe is also concerned with personality and multiple other factors, a large number of neuropsychiatric disturbances like aggression and other things may also be seen. Now, this is as per Brodmann's area, we have different divisions of the frontal lobe. I won't go into this. We come straight to the lateral prefrontal regions, that is on the outward, the lateral side of our brain. Now, these are a variety of regions that primarily work and they produce some executive impairment and particularly in executive skills. So whenever these regions are impaired, as you can also know that partly the Broca's area is there. So verbal fluency is impaired. You see some memory impairments also, particularly difficulties in recollecting, difficulties in monitoring memory. Abstract concepts may be affected. Now, all this is something that you have to ask the patient and test, which is part of your dementia assessment. Sometimes there may be effective planning. So if you give him uh, multiple tasks to do and ask him in what order you will do it, there may be a difficulty in planning. Motor sequencing, we'll come into one of the tests for that later. And cognitive judgment, estimation, etc., also gets affected here. Now, another thing is that uh, so there's an area, the frontal operculum, where we primarily in the left side we see Broca's aphasia, and on the right side, if it gets affected, you see what is called expressive aprosodia. Now, Broca's aphasia, everyone knows, is expressive aphasia, wherein the person will speak either only a few words or probably not talk at all. But expressive aprosodia is that the person talks, but the prosody of speech, that is, the speech is very monotonous. And the person, there is in dementia patients very often the same tone of speech is there, and that is called expressive aprosodia, which you see. We have area 6 and area 24, the green area which you see, the SMA area, supplementary motor area, etc., which has been, and the anterior cingulate, that is area 24, which has been implicated in akinetic mutism. We all see patients where they are mute, they are not moving, they are lying down, though they are not paralyzed, and akinetic mutism may also be seen there as a symptom. There is also something known as the orbitofrontal region, which is the part of the frontal lobe above the eyeballs. And in that region, particularly if there is any lesion there, or stroke there, or vascular deficit there, one may see disinhibition. The person may remove his clothes, walk about without bothering about worries. And we see a lot of patients with dementia that show disinhibition. There is also a lot of altered social conduct. So he may behave rudely, he may be abusive, he may sometimes hit others, and it is referred to as what is called acquired sociopathy or antisocial behavior that you see because of the frontolimbic relationships which are impaired. Well, the basal part of the frontal lobe, particularly if you look at deeper areas like the nucleus accumbens, etc., whenever there are lesions over there, and these are all seen on the MRI also, you may see anterograde amnesia. That is, new knowledge may be an issue. New knowledge may not be learned. And sometimes we see confabulation. Now, confabulation is always a part of the classical alcoholic Wernicke-Korsakoff syndrome, but sometimes you see confabulation in dementia also, where the person, this is these the confabulations that you see here are spontaneous. There are memory gaps. Those memory gaps have to be filled up, and that is why these confabulations are which come in. Now, if you look at the frontal lobe circuits, there is something known as the dorsolateral loop. So the dorsolateral prefrontal cortex is linked to the caudate nucleus, the globus pallidus, and the thalamus. This is a very simple explanation of that loop. But damage to this area can produce inflexibility. A lot of patients with frontal lobe dementia are very inflexible. They don't want any change. They don't want any change in routine. They also have a problem in planning, problem solving, and goal directed behavior. So, this is one circuitry loop in the frontal lobes which are affected. We have the orbitofrontal lobe, where the orbital cortex is also linked to the basal ganglia and the thalamus. And damage here, as we said, there is aggressiveness, emotional lability is there, hyperactivity is there. The person is not sitting still at all. We see a lot of dementia patients who are not able to sit in one place. They are constantly moving. And there is aggressiveness and reduced self-awareness. We have the anterior cingulate cortex, that is a medial part of the frontal lobe, which is also linked to the basal ganglia and the thalamus. And we discussed that akinetic mutism happens here and abulia happens. Abulia is a lack of will. You tell the patient that come for a walk, you tell the patient let's go here. There's a total lack of will on the part of the patient, a lack of desire to do anything. Now, there are multiple neuropsychological domains in the frontal lobe. There is motor activity, attention, personality, visuospatial function, cognitive skills, etc., which are impaired. Now, the most elementary neurological deficits that we see is you may see contralateral hemiplegia or hemiparesis, which we see because of the motor area being affected in a vascular lesion. Sometimes some primitive reflexes will come, like the grasp reflex, or if you try to touch the patient's mouth, he will go and try to, take your finger in the mouth or search for your finger, which is called the rooting reflex. Sometimes if you tap with your hammer on the chin, and he may snout, what is known as a snout reflex. These are primitive reflexes, and you must examine this in every patient with dementia that comes to you. See, dementia examination is a 2 hour, 3 hour procedure. You should take your time out, admit the patient in the ward, examine the patient thoroughly, and do it better than neurology, because we have the neuropsychiatric knowledge to add to our forte. Also, gaze abnormalities, they may have spontaneous gazing from here to there, and conjugate gaze movements, that is both the eyes moving together, may be impaired because we have the gaze area which is also in the frontal lobes. Now, we already discussed about that you see two extremes with frontal lobe damage. Sometimes you may see emotional lability and disinhibition. Sometimes you may see abulia, apathy, and that may be mistaken in elderly subjects to be geriatric depression. A lot of people may mistake it as being geriatric depression and start treatment with antidepressants and find that there is no improvement. But actually, this is dementia that sets in the form of depressive features. Now, this we all know. In every textbook, you will find the famous case of Phineas Gage, where a rod went through his skull, and it was said that prior to his accident, he was a religious, family loving, honest, hardworking man. And after the frontal injury, he was fitful, irreverent, with the grossest profanities, impatient of restraint or advice, obstinate, where and he would plan but abandon them. So this is what was noted in his changes in his personality. Now, frontal lobe symptoms which are not relevant to emotion. So there is a lot of poor self-monitoring. He may not monitor how his clothes are, how he's looking. He may not get arousal very easily. Moria is pathological jocularity. The person may just laugh for no reason. Like a child is running, a child falls down. We're generally concerned that the child has fallen down and nothing should happen to the child. But the person in frontal lobe damage may laugh. See how he's fallen down, see how he's got hurt. And that is called moria. It is pathological jocularity. There is also depression, which may be there sometimes with a lack of concern. And like I said, aggressive behavior may be noted. Apathy is a very common symptom of frontal lobe damage. They just don't care about anything. The daughter-in-law will come and say that I have burnt my hand in the cooker, and he may just smile and pretend or not say anything, and they may feel that the father-in-law has not reacted only. And this is the symptom of apathy. So we have two opposite motor defects in frontal lobes. One is hyperactivity and the other is apathy and abulia. So sometimes there is idiomotor apraxia, that is skilled movement with the hand is not there. If you ask him to fold a paper, if you ask him to button, all these movements may sometimes be impaired. Sometimes there will be a failure to maintain motor activities. If you tell him, keep your eyes closed for 5 minutes, he will open it. He won't be able to keep it closed. Or you tell him to pull your tongue out, he will take the tongue in before you tell him to take the tongue. So that way. Similarly, verbal motor acts, if you tell him stop, go, wait, he may not be able to do it. You keep a glass of water before him and tell him don't drink the water, he may end up drinking the water. So he may have impaired verbal control. He may not be able to follow what you're telling him. So these kind of motor deficits may also be seen. Also, if you ask him to write, you keep writing the letter A in running hand. He may not be able to do these recursive writing sequences. There may be a problem. And he may not, there may be a poverty of movement. So he may be slow in his movement. Though there is no hemiparesis, there may be slow in his movement. So this is an example of the picture. The uppermost picture is a normal drawing, and you see below of patient with frontal lobe damage may not be able to replicate the picture. Then you have the picture below again where MN he's told to write in running hand. But if you see down, the patient with frontal lobe damage is not able to replicate the handwriting. Similarly, recurrent writing, the person is not able to write. If you can see, there are marked discrepancies in the pictures made in a patient with frontal lobe damage. Now, I'm not going to go into the neurotransmitters, but how do we test frontal motor function? So one is hand grip. There are grip machines. How long he can hold the grip is what we test. How fast he can tap the finger is how we test. Static steadiness, whether he can walk without falling. Manual dexterity, tell him hold with the move from left to right, left to right. We tell him he's not able to do it. We give him a maze to solve, whether he can solve maze coordination. Those are things which he's not able to do, and certain other complex tests which I'll come to. Now, the frontal lobes are also concerned with attention. So we see a lot of inattention in patients with frontal lobes. So what are the deficits that we see? There is a difficulty in focusing attention. There is a difficulty in maintaining attention. And there is also difficulty in selectivity of attention. What I mean by focusing, you tell him, I'm going to play a song and I want you to focus and tell me what are the musical instruments that are played in the song. He may not be able to focus. You tell him, I want you to listen to this song for 10 minutes. He won't be able to maintain attention. And you tell him, in this song, I want you to focus only on the drums or only on the flute. He will not be able to selectively pay attention to certain parts. So his attention shifts. So these are part of the attention deficits that we see in frontal disease. How do we test attention? There are cancellation tasks which are there. The digit span test is there. Sentence repetition test is there. There is a trail making test. The digit symbol test from the waist is what we use. So these are tests for attentional function that you can do on the bedside. Human frontal memory deficits, there is short-term memory deficit. So working memory, if you give him a pen and tell him that, okay, this is a pen, how do you use it? He'll say, this is used to write. I can write a letter with it. I can sign with it. So you tell him, okay, show me. He will not be able to open the pen and hold the pen. So maybe defects in working memory may be seen. Susceptibility to interference, he will get easily distracted. If you ask him to memorize, he won't be able to memorize. Long-term memory is also affected. And order of memory, he may forget the dates. So the temporal order, he may not be able to, he'll say, I got married first and engaged later. He may not remember the temporal order of sequences. And he may not know what he has committed to recently. So these kind of frontal memory deficits are also what you may see. Now, these are other examples of how patients with frontal lobes are not able to copy complex figures which are given. These are all bedside tests that you can do by sitting with the patient. This is a model of what is known as it's there in every textbook, the Ray Osterith complex figure test. And below is what the patient, he's drawn a door. He's not been able to draw the figure at all. So these kind of defects are what you can see. Frontal lobes also show executive skill function. What is executive skill function? Planning, goal establishment, anticipation. So we tell him that, okay, what if we give him 5 tasks? We say, you had to go here, go there. Where would you go first? What would you do later? He's not able to tell you. Tomorrow, guests are coming to your house. What all will you do? He won't be able to tell you. So planning is a problem. Also, if you tell him how much food do you think you need for 1 month, he won't be able to tell you how much is needed. So approximately how much rice would you consume in 1 month? So he'll say 1 kilo. Now 1 kilo is too little. He won't be able to plan and tell you how much he will need for the month. Anticipation. If the anticipation that tomorrow this is going to happen is what is, he won't save. He doesn't have that anticipation. We'll tell him, suppose you have 100 rupees today. Would you like to save 30 rupees for tomorrow? He'll say, no, I'll spend all 100 today. So very often, so that kind of thinking is there. And cognitive estimation. He won't be able to estimate what others are thinking. So that also becomes a problem. If you give him some hypotheses and ask him, is it true? Is it false? He'll get confused. He also won't be able to interpret abstract concepts. So we give him a proverb that Rome was not built in a day. He won't be able. In Hindi, we say, Nachna aaye to angan teda. He will not be able to tell you what the proverb means. Similarly, if you tell him what are the similarities between wood and a chair, what are the differences between chair and wood, what is the similarity between a bird and a plane, these are examples which we give where again he'll have a problem. And his verbal reasoning would be impaired. So a lot of informational memory would be lost, particularly working memory of objects. So this is an example of the digit symbol test that you use, and you see impairments do happen. The patient is copying the digit rather than putting the symbol. So these kind of issues do happen. This is an example of, when you tell the patient to draw squares and circles and he makes certain mistakes. Handwriting also, you tell him that sign your name or your signature. He's not able to sign his name. He just writes his name. Similarly, if you tell him that the weather is sunny outside, he's writing in capitals. He's not writing in running hand. So he's not able to follow verbal instructions. So these issues also happen. Now, if you see what the examiner drew and what the patient drew, there's a huge difference in the drawing. This is again a frontal lobe deficit, which you see. Now, here you ask him, this is a picture. Tell me something about the picture. And there is perseveration. The guy is flying a kite, guy is flying a kite, guy is flying a kite, but he's not able to weave a story out of the picture. She's drinking Pepsi, but he's not able to, weave a story that this is a family, they've come on a picnic, the child is flying a kite, the parents are sitting and relaxing, their car is there. He's not able to weave a story about this. So this is what happens in frontal lobe damage. And there is something called utilization behavior. Everything given to them is put in the mouth. So that is called utilization behavior, which you also see in frontal lobe damage. There are different psychological tests that one may use in frontal lobe damage. One is the Wisconsin card sorting test. Then you have the category tests which are there, trail making tests are there. So these are all psychological tests which are available in the market and can be used in frontal lobe damage. This is another example of the recurrent springs where patients with frontal lobe damage are not able to draw these springs when they are asked properly. Similarly, if you give him a number and tell him to follow, he gets confused and he may mark the wrong numbers. He may not be able to follow the numbers as in order. Same thing here. He may not be able to follow the numbers in order and make these mistakes. So that was a little bit of introduction to the frontal lobes. We now go to the parietal lobes, which is the second part of my lecture. So the parietal lobes is a very, very important structure. Also, what is very important is in the prefrontal lobes, we should know that the prefrontal cortex is the last part of the human brain to develop. It develops by around 25 years. Sometimes it takes more, whereas parietal is developed far earlier. And the parietal is our sensory area. The parietal lobe is a rather understudied lobe in our brain, but the parietal lobe is very important because it is like a connection between the frontal, temporal, occipital lobes. It's in the middle, so it is connected to everything. It is mainly the sensory area. Now, what is very important is there are multiple regions, the anterior interparietal region, lateral interparietal area, and the parietal reach regions. These are important for different functions. Now, how do we ascertain that uh, is this patient with dementia having frontal lobe damage? Is this patient with dementia having parietal lobe damage? Is this patient with dementia having occipital lobe damage? We have to do an MRI. And on an MRI, we have to look at multiple areas where there is a lack of vascularity. If the patient can afford, you may do a SPECT scan, but SPECT is not mandatory. If you might do an MRI, and an MRI showing infarcts in those areas is good enough. Now, parietal lobes are closely linked to the frontal and temporal lobes also, but there is one area, this red area which is known as the angular gyrus. The angular gyrus in the parietal lobes is linked to your ability to calculate, your ability to do mathematical problems. And this is something that small mathematics, mental mathematics, addition, subtraction, division is something that we must test in every patient with dementia. Another test for parietal lobe function is these are alphabets and like Z, N, H, and they're to be placed on the palm of the patient, and there are different patterns, and the patient has to identify the patterns as to what they are. Similarly, one of the parietal lobe functions is to match different patterns or objects. So the shapes, so shape perception is a parietal lobe function. So we very often ask a dementia patient, is this shape smaller? Is this shape bigger? He'll get confused. That will indicate to you that there is some parietal lobe damage which is happening. A very classical example of parietal lobe damage is hemi-neglect. And what do we mean in hemi-neglect? What basically happens is that one half of the body is neglected. So he may end up shaving one half. He may end up dressing one side. He may not wear the other pant. He may wear only one leg of the pant. But more importantly, the classical test for parietal lobe function is what is called the clock drawing test. And in the clock drawing test, the classical is when it is at 140, 135, and you ask him to draw the time. You can see here that he has drawn half a clock. He has not drawn the other half. Similarly, you ask him to copy the picture of the house and the flower. One, he has not copied it very accurately, and two, half of the picture is missing. So that is what is the classical symptom of hemi-neglect that you see in parietal lobe damage. Similarly, with the flower drawing, half the flower is there and half is not there. Spatial perception, shape perception is a parietal lobe function. So you may have a photograph like this, which you keep, and there are two separate flashcards, A and B. and the person may be asked, what is he seeing? And he may say, I see a bucket. And you ask him, what do you do with a bucket? He says, I take a bath. Now, the same bucket is shown to him with an above view. So whether he still recognizes it as a bucket or does he perceive it as something else? One of the parietal lobe functions is that we are able to recognize the object irrespective of whatever view I see it. So for example, this is a water bottle. Whether I show it to you horizontally, whether I show it to you this way, whether I show it to you this way, you're still able to perceive that this is a water bottle. Same way, he's supposed to perceive that the bucket is a bucket, whether you show it to him from the side or whether you show it to him from above. But this becomes a problem in parietal lobe damage. There is also the serial hand movement copying test, where the person puts his hand on the shoulder, he puts it here, and then puts his finger. This sequential movements are something which get damaged in parietal lobe function. Similarly, the face copying test. He frowns his eyebrows, closes his eyes, and pouts. And you ask him to copy this in sequence. This becomes a problem. These are bedside tests for you to assess parietal lobe damage. Similarly, there is this machine which is available where you push a button with the index finger, pull the handle, and press the bar with the thumb. Again, this machine is very easily available for, I think, 500 rupees or something, and it's available in many psychological testing facilities. All you can do is use this, and the person is not able to do this, perform simple functions. He's not able to press a button, he's not able to press the bar, he's not able to pull the handle. These are also parietal lobe functions that sometimes come up. Now, what happens in parietal lobe functions, as you can see, there are different areas which are affected. So you have tactile agnosia. You give him a pen, ask him to close his eyes and tell you what it is. He's not able to feel and tell you. So that's called tactile agnosia. There may also be misreaching. You tell him to pick up a cup, he may go ahead of the cup and may miss the cup. He may not be able to tell you if the bucket looks a bucket from the side or above or below. So manipulation of objects becomes a problem. There may be apraxia. He may not be able to do coordinated movements. Constructional apraxia. You ask him to draw something, he may not be able to draw. The patient may also have acalculia. Simple mathematical calculations may be a problem. Hemi-neglect we spoke about. And many of them have disorders of body image, which could also be caused by parietal. They may feel this is not my body, I'm not looking proper, multiple things. There may be right-left confusion that you may see, and disorders of drawing or spatial ability may also be seen. We now move to the temporal lobes. If you look at the temporal lobes, there are multiple areas. We have three gyri: superior temporal gyrus, middle temporal gyrus, and the inferior temporal gyrus. And the temporal lobe is, of course, an integral part of the limbic system. It is partly linked to the occipital lobe also, and the receptive speech area, the Wernicke speech area is there. The auditory area is there in the temporal lobe. And if you look at the medial part of the temporal lobe, we have certain important areas like the uncus, which is linked to epilepsy, the fusiform gyrus, which is for face perception, parts of the corpus callosum, and the parahippocampal gyrus, which is also part of the limbic system, is also something which is there. Now, the temporal lobe has a lot of connections to the hippocampus. So the memory center of the brain is through the temporal lobe. The temporal lobe has also multiple connections to the amygdala. So the anxiety aspect of fear, the emotional aspect is also there. Now, there are auditory areas which are there. I'm not going to go into this. Now, one of the things is that if understanding rows and columns and categories and shapes is a temporal lobe function, the temporal arrangement of objects becomes impaired in temporal lobe function. Similarly, now this is a very classic test for temporal lobe dysfunction known as a Thatcher illusion, because the facial recognition area is there. And if you ask which face is proper and which is not proper, a person with intact temporal lobe function will tell you that the face on the right is what is abnormal and the face on the left is what is normal. And these are bedside tests that you can use. So we have in facial perception, the temporal lobe has multiple functions. We have the fusiform face area, which only looks at perception of face. How do I recognize? Like, how do I know if I see Dr. Patil from far away? How will I know that he's Dr. Patil? I will know because I recognize his face. He will know because he recognizes my face. So the fusiform face area helps to recognize my face. Let's say I have a long beard and like Rabindranath Tagore and a mustache. Sir may still recognize me because of my body structure, but he may look twice or thrice to first see whether it is me or not, and then finally recognize me. So there again, the fusiform face area plays a role. Now, the temporal cortex also plays a role in personal identity. Once I recognize the face, which part of my temporal lobe is going to tell me the name and biographical information? The anterior temporal cortex will tell me that. Now, why this is important is because we ask the patient to bring an album with different family members' photographs. And we ask the patient to identify who these family members were, what they do, how they do, who they are, what work they are doing. So that is there. Emotional expression, that is the changeable aspects of faces, lip expression, gaze expression, is also of temporal lobe function. So we have people laughing, crying, sad, angry. So we have different facial expressions also, which are a part of temporal lobe function. And of course, it is linked to the limbic system also. So that is one important facet. Now, here again, if you look at the picture on the left, it is normal. The picture in the middle is joining of two left halves. The picture on the right is joining of two right halves. So he has to identify which picture is symmetrical. This again is a temporal lobe function which is done. Music is an area which is affected by temporal lobe. So if you get any patient with dementia who tells you that I'm not able to enjoy music, probably he may be having what we refer to as amusia or a loss of the ability to enjoy music. And that may be a part. So he may not be able to tell you what is loud music, the pitch of music, whether it is loud or whether it is small is something that he may not be able to tell you. So when we look at temporal lobe damage, what are the multiple symptoms that we see? There is a disturbance of auditory sensation because the auditory area is there. Auditory perception, he may not be able to perceive sounds. What sound it is, he may not be able to tell you. You give him music, he may not be able to perceive music. Language comprehension, because the receptive area is damaged there. Very importantly, hypersexuality or hyposexuality may be a symptom of temporal lobe damage, and changes in personality is what you may see. And memory deficits, long-term memory deficits are a frontal lobe function. Now, you can use an fMRI to understand how things are, but sometimes you have to also see that when you assess for aphasia, you also have to see whether maybe it's the Wernicke's aphasia isn't there, maybe the Broca's aphasia isn't there, maybe what is there is called transcortical aphasia, that is the arcuate fasciculus, the bundle of fibers that are joining the Broca's area and the Wernicke's area are what is affected. This is another example of certain mazes, certain figures to judge temporal lobe function. The Raven's progressive matrices is a test that you can use to judge temporal lobe function. We now go to the last part of my lecture, which is the occipital lobes. These are all things you can do bedside. And the occipital lobes are the least studied lobes because we don't normally deal with visual defects in our practice. So the occipital lobe is very, very important because there are 7 parts or 8 parts labeled from V1, V2, V3, V4 to you have V4 dorsal and ventral, V5, V7. So those of you who are interested, the occipital lobes and vision have been extensively described by a scientist called Seymour Zeki. So a lot of the work on occipital lobe is by Zeki. So do read his work. You'll get an interesting insight into the occipital lobe. So V1 is the homogeneous cortex. V2 is the heterogeneous cortex, and it's also called the striate cortex. So V1 and V2 are mainly concerned with vision. So there are stripes on this cortex which are seen. Color vision is a part of V4. So how do I identify color vision? We carry a box of crayons with us and ask the patient to identify the different colors. Or we point to the colors of shirts that people are wearing and ask the patient to identify colors. So even apart from color vision, also depth. We ask him to look out of the window and estimate which floor he's on. We ask him what is to your left, what is to your right, and ask him to estimate position. Now, what is very important is that even facial recognition is a part of the occipital lobe and temporal lobe combined together. I'm not going to go into these details, but what is very important to understand that vision defects begin in V1. So any patient who complains of a loss of vision or cortical blindness is something that you will see happening because of a lesion in the V1 area. So vision related areas in the brain make up around 50% of the total cortex. Vision is not unitary. It is not only in the occipital lobe. There are different categories of vision that we see. Now, if you can see here, what are the types of vision that we see? One, object analysis. We analyze an object, which is a lateral part of the occipital lobe that plays a role in analyzing what an object is. We have something known as the extrastriate body area, which analyzes body, whether how big my body is, how small my body is. Here you see a symptom called uh, macrosomatotypagnosia, where the patient may feel my limbs have become bigger or my limbs have become smaller. Microsomatotypagnosia is what we call it. The fusiform face area is for facial recognition. The fusiform body area is for recognition of body parts. We ask the patient to identify his thumb, to identify his nail, to identify his toe, to identify his lips. So that is it. The analysis of biological motion. So we show the patient a video, whether the car is moving fast, slow. We play the video at different speeds, ask him which video was faster, which video was slower. So that's also something that is done here. And an analysis of landmarks. Now, very often we get some patients with dementia who are not able to ascertain landmarks. He's not able to identify a church, a yellow building, multiple things. That is a parahippocampal place area, which plays a role there. And of course, voluntary eye movement, visuomotor skills, all these areas are affected also by the occipital lobe. Now, there are, as I said, 5 categories. So there is vision for action. So you give him a ball, whether he's able to catch the ball, whether he ducks to avoid the ball, whether he's able to reach for the ball, multiple things are assessed. Visual scanning, whether he can scan how the ball is coming. That is also something that we, do play a role. So, location of an object relative to the person. We place an object and tell him where is the object in relation to you, which is called egocentric space. Then we may say, where is the object in relation to another person, which is called allocentric space. So all this has to be assessed. These are all parts of occipital lobe function. And finally, visual attention. We tell him that in this flow of things which are coming, you will see a duck. Whenever you see a duck, you're supposed to tell me, yes, I see a duck. So that is called visual attention, whether he's able to focus on a specific detail. So these are all different bedside tests. So normally what I tell many resident doctors is that you actually need to prepare what I call a dementia neuropsychological bedside kit. And when you have a bedside kit, then you can work with patients and actually study different neurological symptoms. I will probably also try and prepare some notes from concise notes from the chapter of Leishman because it's a big chapter. So more in the form of what is the deficit, how do you test it, which area of the brain is involved. So that would be like a ready reckoner for you to know, what do I do and when do I do. So object recognition, temporal and visual together. Action, how do you use an object, is parietal and visual together. So multiple visual areas play a role there. No, this I'm not going to go into. Yes, one of the hallmark deficits in the occipital lobe is what is called object agnosia. You give the person an object. There is a deficit to develop a perception of how it is. Is it rough? Is it smooth? Is it so apperceptive agnosia? Whereas associative agnosia is when he can perceive objects. He will use a pen, but he will not be able to identify a pen. And we have something known as simultagnosia. He cannot perceive more than one object at a time. In simultagnosia, what happens is you give him a photograph and tell him, describe the photograph. He'll tell you, I see a tree, I see mountain, I see a sun, but he will not be able to tell you that it's a beautiful scenery. That is what is referred to as simultagnosia. He's not able to make sense of the entire picture as a whole. He's able to identify objects. One of the other things is inability to recognize faces, which is called prosopagnosia, which you may see as an occipital lobe defect also. Even inability to read. Remember, this is alexia, inability to read, not dyslexia. The person may not be able to read because he's not able to look at letters, not able to identify letters. So that is what also you may see here. No, I'm not going to go into this. Yes. So these are all the things that, I sort of wanted to just give you an overview that, and there's much more. Bedside testing in dementia has far more things. I will, in fact, prepare some notes and probably send it, and you could put it up on the website for everyone to access. And I think we could take this further from there. So that's all I had to share with you all today. And if there are any questions, I'll be more than happy to answer them.
It was a very nice presentation. Avinash, you have given a very good examples, what you have shared. That were really nice examples. And you have given a lot of information also. So thank you very much.
Thank you, sir.
If there are any questions, you can ask the questions.
We'll request everybody to post their questions in the chat box, please. I think you were lucid enough for us to not have any questions. Everybody's got it all clear.
No, but I will still say that they have to go and read the second chapter of Lishman. If they go and read it only, then they will be able to assimilate all that has been said.
With the permission of the chair, can I ask a question?
Sure.
What are the best testing modalities to be able to assess the different subtypes of dementia, the areas affected, as well as to be able to identify which lobes are more affected than the others?
No, so generally what we do is, what is advised is you start lobe-wise. We don't go with either you assess symptomatically first, and on the basis of symptoms, you decide that, okay, he has more occipital symptoms or more parietal symptoms. But relatives have to sometimes be able to catch those symptoms and tell you, which they don't. So the only way is, if you admit a patient, you do extensive bedside evaluation first of frontal, note the defects, note what is not affected, temporal, note what is, and then you come to know which is the most affected lobe. Now, if that matches with your MRI findings, then that gives you conclusive evidence.
Fair, but are there any standardized tests that we do?
There are a lot of neuropsychological batteries which are available. There is Luria, Nebraska, there's a Bhatia battery, there are multiple batteries which are available. But the thing is that these take a long time, and they definitely are also expensive, and they can be used and they have all the tests on it. But beyond that, uh, I mean, you have to be trained in it, of course. So that's something which is very important. Chetan wanted to know for Levy body. Well, Levy body is always a post-mortem diagnosis. We don't have anything for it pre, but on the basis of symptoms, for example, more motor symptoms, uh, excessive, I would say, a lot of sensitivity to antipsychotic medication. All these things go in favor of Levy body, and particularly if you see more of a frontotemporal damage than temporal alone.
Yes, sir.
Yeah.
So, thank you, sir, for taking up those questions. So, if any other questions are there from the postgraduate students, they can type it in the chat box. So otherwise, I would request Patil sir to give any concluding remarks.
Avinash, as already I have told you, it was a very nice presentation. You have talked about something very recent and like regions of proposed function, visual scanning, uh, and object agnosia, prosopagnosia, alexia, and other things. I would like to ask you, Avinash, are there some differences in presentation of dementia globally and in India per se?
Sir, I don't think symptom-wise there are differences. What happens is, uh, we don't normally do detailed neuropsychological evaluation for dementia. We just assume that it's dementia, and we don't go and look at individual functions and what is affected. And that is why I think we don't normally assess. But if you have a rehab, admit a patient, spend a lot of time and assess, I think it's worthwhile. It's very interesting, but it's more out of personal interest that you should do it, because some of these deficits are not reversible. Some of them are reversible. So it's something which is there.
So
Thank you.
yes,
Thank you.
yes,
Chetan sir,
yes, sir.
Rashmin sir, it is a very good initiative, as already I have told you, and it is helping our PG students a lot. Like most of our PG students, they are attending these Thursday evening uh, topics and everything, and more and more students and even faculties, they should take interest in attending such type of activities. Thank you very much from my side.
Yes, sir. Definitely, we'll take up all the suggestions and any topics that all the senior faculties suggest. With this, we come to an end of today's session. It was truly revisiting all the post-graduation days, and definitely, sir, it's a very complicated topic. Thank you for simplifying it. Avinash D'Souza sir has simplified with wonderful examples. I express my heartfelt gratitude towards Avinash D'Souza sir for making this difficult topic a simpler one. I also extend my sincere thank to our esteemed chairperson, Dr. Pradeep Patil sir, for taking out time and chairing today's session. And many thanks to all the participants for their uh, presence for today's session. Thank you to all the organizing team, the tech team support for their unconditional support throughout this session all these years. Thank you all once again.
Thank you. Thank you all. Have a great evening ahead. Thank you, Chetan.